In ventricular septal defects, we see a defect in the septum that divides the left and right ventricle. As such, we see aberrant blood flow across this defect from the left to the right ventricle. This occurs as a result of the differences in pressure between the two ventricles. The left side of the heart has a much higher pressure than the right ventricle does. The left ventricle has a much higher pressure than the right ventricle, and as such, blood will preferentially travel from the left to the right side. The murmur is best heard in the tricuspid area because the right ventricle is closest to the chest wall in this location, which is the fifth intercostal space along the left parasternal border. Similarly to mitral and tricuspid valve regurgitation, VSD is a holosystolic murmur. It is a murmur that is heard, appreciated through the entirety of systole. So now the question is, in a patient with a holosystolic murmur best appreciated in this tricuspid area, how do you differentiate between a ventricular septal defect and a tricuspid regurgitation? Because remember, both of them are holosystolic murmurs appreciated in the same anatomic area. The key difference between these murmurs is how they radiate. So the sounds, or the murmur itself in tricuspid regurgitation, radiates up to the right. You can actually hear the murmur closer to the right shoulder. In patients with ventricular septal defect, you do not hear any sort of murmur radiation to the right shoulder. So that's really the key clinical finding or physical exam finding that will separate VSD from tricuspid regurgitation. Ultimately, an echocardiogram or a sonographic imaging of the heart will be really the best way to differentiate between ventricular septal defect and a tricuspid regurgitation defect. So now we're going to move on to murmurs that occur in diastole, or diastolic murmurs. There are only two murmurs that occur in diastole that are important to know for step 1, and that is aortic regurgitation and mitral stenosis. Let's first begin discussing aortic regurgitation. Aortic regurgitation is exactly what it sounds like. It is regurgitation of blood from the aorta back into the left ventricle because of an incompetent aortic valve. Eventually, this regurgitated blood will overwhelm the left ventricle and progress to systolic dysfunction. So over time, we get blood flow both from the left atrium as well as regurgitating back from the aorta. It overflows and fills up the left ventricle, causing a dilation of the left ventricle, and eventually results in systolic dysfunction and even heart failure. What are some common etiologies of aortic regurgitation? The three most common etiologies are wear and tear on a bicuspid aortic valve, which we remember can also cause aortic stenosis. It can also be an etiology of aortic regurgitation. We can also see aortic regurgitation develop in infective endocarditis. We can also see it develop in rheumatic fever. Those are the three most common etiologies. It is also seen in patients that have an aortic dissection or have long-standing hypertension resulting in left ventricular hypertrophy. It is seen in patients that are a little older, and in general it's idiopathic in over 80% of cases. So once again, this is a diastolic murmur. It begins after the S2 heart sound, and it's really what is known as a decrescendo murmur. It starts the loudest and slowly tapers off until you can't hear it anymore. It is best appreciated in the left parasternal area. Although it is the aortic valve that's incompetent, it's not heard in the aortic area. It is heard best on the other side of the sternum as the blood regurgitates back in from the aorta into the left ventricle. So in review, this is a diastolic murmur. It is a result of incompetent aortic valve that results in blood flow regurgitating from the aorta back into the left ventricle. It's seen in patients with old age. It is seen in patients with bicuspid valves, infective endocarditis, rheumatic fever, aortic dissection. It is a decrescendo murmur that has greatest intensity immediately after the S2 sound and then tapers away. The other most common diastolic murmur is mitral stenosis, or narrowing of the mitral valve between the left atrium and left ventricle. Mitral stenosis is a classic pathognomonic finding of rheumatic fever. And you remember the pathogenesis behind rheumatic fever? Well, remember, rheumatic fever develops after a pharyngitis from a group A Streptococcus pyogenes infection. The immune system produces tons of antibodies to bacterial antigens such as the M protein, and these antibodies cross-react with proteins present on the mitral valve. These antibodies deposit along the valve, causing inflammation, and then ultimately, after a long period of time, it leads to fibrosis and thickening of the mitral valve leaflets. And over time, this inflammation and fibrotic change leads to these valves actually fusing together and cause a functional narrowing of the mitral valve. So here we can see in a normal mitral valve, we have free movement of the mitral valve leaflets. The mitral valve leaflets sort of swing this way when the left atrium pushes blood into the left ventricle. It's the normal function of the mitral valve leaflets. However, in mitral stenosis, we see this domed configuration. Where the leaflets themselves actually sort of billow inwards and cause a narrowing, or a smaller ostia for the blood to flow from the left atrium to the left ventricle. You can see here a pathologic image from a stenotic mitral valve. We can see that this small slit-like narrowing caused by this heavily fibrotic mitral valve. Blood flow across this narrowed mitral valve creates a characteristic diastolic rumble that occurs after an opening snap. This OS is opening snap. The opening snap occurs from the valve leaflets bulging out like a dome and not letting blood flow until there's enough pressure created by the left atrium that snaps open the leaflets, making an appreciable noise, followed by the blood flow through the stenotic valve causing this diastolic rumble. So before this opening snap, blood is actually not flowing across the mitral valve. Enough pressure needs to build up to push open this fibrotic valve, creating this opening snap, and followed by this rumble or turbulent blood flow through this narrowed mitral valve. As the stenosis gets worse and worse, you start to hear the opening snap sooner and sooner. This is not a good sign. The closer the opening snap is to S2, the more severe the fibrotic valvular disease. The murmur itself is best heard in the mitral area, which is in the mid-clavicular line in the fifth intercostal space. And over time, it's important to consider what a mitral stenosis does to the heart. So chronic mitral stenosis is a bad thing for the left atrium. It's a very bad thing for the left atrium. It's causing the left atrium to have to push against the higher afterload, or the stenotic narrowed valve. This increases left atrial pressures. It causes dilation of the left atrium. And this is very bad. This can lead to a number of significant changes in our heart's physiology. Importantly, the left atrial stretch can cause electrophysiologic connections in the atrium to be compromised. So these electrophysiologic changes occur and predispose these patients to the feared atrial fibrillation. So atrial fibrillation is a sort of feared complication of severe mitral stenosis. Left atrial dilation can also result in areas where blood flow becomes static. It sort of hangs out in this sort of corner of the left atrium, and the blood doesn't flow very well, and clots can develop. So you can have some thrombotic complications in patients with left atrial dilation from mitral valve stenosis. Also, there can be local compression on structures from this severely dilated left atrium. You can cause compression of the left recurrent laryngeal nerve, causing hoarseness. You can compress the esophagus, causing dysphagia. You can even compress the bronchus, leading to dyspnea and problems breathing. So mitral valve stenosis can lead to left atrial dilation or dilatation, which causes significant pathologies locally, as well as causing pathologies within the atrium, including atrial fibrillation and clot formation within the atrium. So now we're going to move on to continuous murmurs. And these are murmurs that occur throughout the entire, they continue throughout the entire cardiac cycle, both systole and diastole. The most common murmur that is continuous is patent ductus arteriosus, or a congenital cardiac defect in which the ductus arteriosus, or the fetal connection between the aorta and the pulmonary artery, is maintained in early life. It's maintained in early life. It remains patent. And ultimately, this patent passageway between the aorta and the left pulmonary artery results in turbulent blood flow, going from the aorta, or an area of high pressure, to a system of low pressure, or the left pulmonary artery, low pressure. So this turbulent flow causes a continuous murmur because blood is always flowing from the aorta to the pulmonary artery, whether or not we're in systole or diastole. The two most common etiologies of patent ductus arteriosus are premature babies and congenital rubella. Congenital rubella. In normal newborns, the smooth muscle in the ductus arteriosus proliferates and eventually causes fibrosis and obliteration of this ductus, leaving the remnant. Do you remember what that's called? The remnant of the ductus arteriosus is the ligamentum arteriosum. You usually have a ligamentum arteriosum here. However, if you are born prematurely, there's not enough time to do this. It's a simple way of thinking about it. There's not enough time for this ductus arteriosus to close, and so it remains patent early in life, causing this continuous murmur. Rubella, on the other hand, loves to infect endothelial and smooth muscle cells, and so it can disrupt the normal contraction and closure. The cells apoptose, the smooth muscle endothelial cells apoptose, they die and do not present themselves to close this patent ductus arteriosus. So as we discussed, this is a continuous murmur. It is a continuous murmur that occurs throughout systole and diastole. And why is that? Well, because there's always this gradient, as I just sort of mentioned, there's always a gradient between the aorta and the pulmonary artery that enables flow. There will always be flow from this area of high pressure to low pressure, resulting in turbulence that is appreciated by a stethoscope on auscultation. So we can see here in this image, the murmur is best appreciated right over where the patent ductus arteriosus is. And this is really in this infraclavicular region on the left chest. This is a very characteristic murmur, one that exists through systole and diastole, and it's something that is very high yield for your step 1.